We will start directly with Professor Ira Yu from Philippines. She's there? Yeah, come please. Professor Ira Yu that will talk about approach to liver failure, the old and the new. Professor Ira Yu is a fellowship in gastroenterology, hepatology, transplant and pathology training in California Pacific Medical Center. She is Associate Editor for Philippine Journal of Gastroenterology, Head Section of Gastroenterology, National Kidney and Transplant Institute, and Committee Member, Guidelines Committee and World Gastroenterology Organization. Please.
Okay, good afternoon, everyone. I was asked to talk about liver failure, the conventional concepts, and the new treatment approach. Liver failure per se is a very broad topic, and I would just touch on some generalities so that I would hopefully fit in my allotted time slot. It's not moving. So for this session, this will be my talk points. There are two types of liver failure. We have acute liver failure and we have ACLF, or acute and chronic liver failure. Acute liver failure means that you have hyperbilirubinemia, you have severe coagulation derangements, you have encephalopathy in a person with no prior history of liver disease. Now, in contrast, when you say ACLF, you have the same coagulation derangements, you have the same level of hyperbilirubinemia. You can have encephalopathy with or without ascites, but in a person with a pre-existing chronic liver disease, whether it's cirrhosis or non-cirrhotic. Now, there are a lot of disease conditions that can lead to liver failure. It could be due to viral hepatitis, it could be due to blood carry, it could even be due to Wilson's disease and autoimmune hepatitis. Now, please, I would like to put emphasis that the clinical appearance of hep-NCEF can sometimes be so subtle and it can be missed by a lot of physicians. Therefore, we have to be very careful when we are dealing with a liver patient because we do not want to miss this manifestation. Now, there is a geographical difference in the etiology of liver failure. And as you can see here, the predominant cause of liver failure in the West is still DILI, with paracetamol being the leading cause. But in Asia, viral hepatitis is the predominant cause, mostly viral hepatitis B. There are right now 4 trajectories of liver decompensation. We have the stable decompensated cirrhosis, we have unstable decompensated cirrhosis, we have pre-ACLF, and the ACLF itself. When we say stable decompensated cirrhosis, we mean that yes, there is decompensation, but in terms of systemic inflammation, it is quite low. And the good news is your patient has a high likelihood of recompensation. In unstable decompensated cirrhosis, you have more decompensation. There is a higher prevalence of bacterial infection. And as you can see in the graph, as you move from stable decompensated cirrhosis to pre-ACLF to ACLF itself, there is a higher likelihood of systemic inflammation. Right now, there is not much literature on the effect of metabolic syndrome and the survival of liver failure patients, but this is one of the earlier studies. This is among Hep B patients with ACLF, and as you can see here, the concomitant presence of metabolic syndrome had resulted to lower survival rate among liver failure patients. Now, there is such a thing as liver failure reversibility, and it happens. By definition, you have liver failure reversibility if there is a decrease in bilirubin below or equal to 5, there is reversal of coagulopathy to an INR less than 1.5, and of course, there is resolution of encephalopathy. Now, what is the toxin hypothesis? It's a relatively new concept in liver failure. It simply means that if you have a failing liver, there is so much accumulation of toxic substances in the system, and this is presumed to be the cause of end organ dysfunction. Now, this slide simply emphasizes that there is systemic inflammatory response and that it is the one that is responsible for transitioning your liver patient from a stable liver disease condition to one with progressive liver injury and organ failure. And as you can see here, the abundance of your TNF, your interleukins, your CRP are the ones that may be responsible in the development of hyperdynamic circulation. And if that occurs, then you have the complications like variceal bleeding, encephalopathy, even your HRS. This is just a slide showing the different inflammatory mediators that are abundant again in patients with liver failure. So again, there is interferon, TNF, interleukins, and on the other side would be the different outcomes of the different cytokine abundance. Now, needless to say, there are many organ complications in liver failure. Again, I will not go through them one by one. I will just touch on some generalities. Now, this graph is just to emphasize, again, that there is a linear relationship of organ failure and mortality among liver failure patients. And as you can see here, the more organ failures that there is, the higher the patient's mortality. Now, let's go to hepatic encephalopathy. There are a lot of hypotheses for the development of hep-NCEPH. They say it's due to alteration in intestinal microbiota. They say that it's due to an abundance of GABA or ammonia or even an amino acid imbalance. Now, serum ammonia has been used as a simple surrogate marker for hep-NCEPH. And you know, it's available. You can use it, you can request it, but again with emphasis, I would like to say that NCEPH is more of a clinical diagnosis. Now, lactulose, rifaximin, ammonia-lowering strategies, they remain to be the main treatment for NCEPH in patients with liver cirrhosis. Now, how about the coagulation parameters of your cirrhotic or liver failure patients? Basically, in liver failure, there's so much alteration in primary and secondary hemostasis, and this would result in either bleeding or thrombotic episodes. And the problem is that if you have a coexisting circulatory dysfunction or sepsis or SIRS or even renal insufficiency, then that would intensify more the coagulation derangements of your patient. In general, the routine use of FFP and other coagulation factors is really not supported unless the INR is more than or equal to 1.8, or your patient is about to undergo an invasive procedure, or if the patient is suffering from an active bleeding. In terms of PAC-RBC transfusion, the guidelines right now is to transfuse only if the hemoglobin is less than 7, or if you have a CAD patient or a CVD patient, then you can transfuse with a hemoglobin of 10. Now, renal dysfunction is also common in liver failure. It occurs in 1 out of 5 of liver failure patients. It is detected in 20 to 50% of hospitalized patients. And as you can see here, again, there are a lot of factors that can lead to kidney injury in your cirrhotic or even your liver patient. Right now, the drug combination with the most data or evidence in the treatment of HRS is a combination of terlipressin and albumin. Terlipressin is a vasoconstrictor. It acts by counteracting splanchnic vasodilatation and renal vasoconstriction. Eventually, it improves renal perfusion. It is being given right now as an IV bolus between 0.5 to 1 milligram every 4 to 6 hours, but you may adjust the dose until you get your desired creatinine. Now, when do we do renal replacement therapy? The indications based on EASL is if you have persistent elevated ammonia, persistent uncontrolled hyponatremia, persistent metabolic acidosis. So again, in general, in any patient presenting with liver failure and severe liver decompensation, the first thing really in management is to identify the acute liver insult and address it. Then you give your specific treatment. If your patient is suffering from hepatitis B, then by all means give your nucleotide analogs. If it's due to Hep C, give your DAAs. If it's due to a fulminant autoimmune hepatitis, you can give your immunosuppression or even steroids. But in addition to this, you give organ support. You may also consider the use of artificial liver support system, and if you have a liver center, okay, that caters to liver transplantation, then most likely you need to refer your patient to these hospitals. Now let's go to liver support system. It is being used now as bridge to transplant or bridge to liver recovery. There are two types. We have the artificial liver support system and the bioartificial liver support system. DPMAS belongs to the NBAL, or the non-biologic artificial liver support system. These are the identified toxins that are usually retained in a patient with liver failure, and as you can see, there is an abundance of both water-soluble and albumin-bound toxins. DPMAS simply means double plasma molecular adsorption system. Again, this is a non-biologic artificial liver support system. It consists of two cartridges. We have the anion exchange resin, which is very specific for adsorption of bilirubin. And we have a neutro-macroporous resin, which is more for adsorption of ammonia. Now, why do we need artificial liver support system? Well, because we want to prevent further necrosis of liver cells. We want to bridge our patient as much as possible to liver transplant, and because we want to prevent and treat other liver complications. So when you use an artificial liver support system or DPMAS, what happens is that the toxins that I mentioned a while ago are actually cleared when they pass through the adsorber columns. Now, this is one of the earlier studies on the use of DPMAS, but in this study, they combined DPMAS with plasma exchange, so they came up with two patient groups. They had a total of 162 patients with clinically significant hypertension. And as you can see here, those who had, in addition, DPMAS, they exhibited lower T-bill, D-bill, and ALT. They also monitored cholinesterase, which is an inflammatory marker, and it happened to be lower among the DPMAS-treated patients. Now, in terms of inflammatory markers, those who received DPMAS also displayed lower CRP, lower TNF, lower interleukin-6 from week 1 to week 2 to week 4 compared to those who did not receive DPMAS. Now, randomized controlled trials of plasma exchange and combined plasma exchange and DPMAS for treatment of ACF were also conducted, and the authors of this meta-analysis showed that the combination of these two systems can actually improve liver function, improve coagulation function, and blood parameters among ACLF patients. Now, this slide was previously shown by Professor Claudio, and again, this is a meta-analysis that just demonstrated that the combination of DPMAS and plasma exchange improve, I would say, the 90-day survival rate of patients. Now, our institution, the National Kidney and Transplant Institute, had its first liver hemoperfusion last 2018. Our first patient was an acute on chronic liver failure patient. Of course, I would be honest that at that time, we were so not familiar with the technology, and we've been calling people left and right to assist us. But after this, people were trained. People also became familiar with the process. During that time, our assistant medical director, Dr. Dangilan, she convened nephrologists and hepatologists. We had several meetings, and we came up with a manual on blood purification through sorbent technology. Now, the surge of COVID has increased the use of this sorbent technology, specifically the sepsis cartridge. So we were able to publish our second edition of this manual. And I would say that this has been very helpful, not only for the physicians inside the National Kidney and Transplant Institute, but also other physicians practicing in the Philippines. Now, this is a list of the clinical indications on the use of DPMAS that we had incorporated in the manual. So we've used it for ALF, for ACLF, for those with post-cardiac surgery liver failure. We've also used it to some patients with very severe leptospirosis. This is just an initial case series report. I would say that there are still a few more patients that have not been put here, and I have tasked one of my residents to actually gather all the patients' chart, and hopefully we can come up also with a manuscript. And as you can see here, not all survived, okay? 2 of these patients in the initial report actually expired. Okay, but we were able to save more patients, 2 of whom had liver transplantation, and they are actually doing well right now. So in terms of parameters, we measured ALT, the T-bill, the D-bill, the INR, the CREA. We also monitored the ammonia, but I'm sorry I failed to incorporate here. But as you can see, a lot of patients had more improvement in the liver function test. These patients, on the average, receive 3 to 4 DPMAS sessions. These are the guidelines that we were able to formulate, and we've included it in the manual. As you can see, these were just patterned after most of the studies that use plasma exchange and DPMAS. I would, however, like to emphasize that we modify some of the guidelines, okay, depending on the clinical situation of the patient. So if we are going to use bilirubin hemoperfusion alone, we can use CRRT. If some patients would only require ammonia hemoperfusion, we can use only a regular hemodialysis machine. But in DPMAS, where you use 2 cartridges, we use CRRT machine. But I guess there is now a hemoperfusion machine that sometimes you could use as an alternative to your CRRT. But regardless, okay, of what cartridge you use, there should be a central access. Now, how often do we do it? We do it every 2 to 3 days until we achieve the goal that we want. Well, ideally, it should be a bilirubin that is less than or equal to 5, but I would be honest that not all patients were able to achieve this. It depends on what you feel is already an acceptable bilirubin for you. Like, for example, some patients would just have a bilirubin of 9 or 10, but really greater improvement in clinical status, then we stop there. We also do it until there is resolution of encephalopathy. Now, how long do we hook patients to the machine? We usually hook them 2 to 3 hours per session. And then we also try to seek the help of our hematologists, and based on their recommendations, we transfuse blood products if platelet is less than 75, if INR is more than or equal to 1.5, or if there is severe pedicay or hematoma. Again, these are our guidelines, but these are based on what has been in the internationally published liver support system. But again, guidance statements can always be modified depending on the clinical situation. Now, when you're dealing with a liver failure patient, it is always a complicated matter. You cannot do it by yourself. That's why we gather a team. So there should be a gastrohepatologist on the team. We call in our nephrologist friends because I would say that they are really the ones very familiar with the dialysis and the CRRT. We cannot do it by ourselves. We call in our intensivists, okay? Sometimes we call a vascular person to just insert the central access, and then we train dialysis nursing staff and technician. So to summarize, liver failure and severe liver decompensation are caused by several conditions and have always been associated with very poor prognosis. There is a multitude of toxins and inflammatory cytokines that are present during liver failure. DPMAS is used, okay, for patients with liver failure and severe liver impairment as a bridge to transplant or as a bridge to liver recovery. DPMAS absorbs ammonia, bilirubin, cytokines, and other inflammatory mediators, and I hope that we could have more validation on this hemoadsorption technology in the near future. I guess this is my last slide. I hope all of us can put a ding in the universe. Thank you.
Thank you very much, Professor Yu.